Good evening to everyone and welcome to this exciting session of our journal club, EnGioI. Tonight we have the great pleasure of hosting a brilliant young researcher and clinician, Dr. Elisabeth Nowak, who will guide us through the challenges of diagnosing of cyclical Cushing syndrome with a bit of insight of her recently published systematic review. Let me tell you a bit about Elisabeth. She studied medicine in Munich and Oslo, completing her degree in 2020. Since 2021, she has been working at LMU Hospital in Munich. And then in 2022, she joined Professor Martin Reinke Research Group with a scholarship for research on rare but important syndromes in endocrinology, focusing particularly on endogenous Cushing syndrome. As a clinical scientist, she splits her time between research and clinical work, contributing to translational research projects on immune phenotyping in cortisol excess and deficiency, as well as large multi-center studies on cardiovascular outcomes in patients with primary aldosteronism and autonomous cortisol excess. And her ultimate goal is to advance diagnostic approaches and optimize personalized therapeutic care for patients with primary aldosteronism and Cushing syndrome. On a very personal note, I just want to add that I had the pleasure of meeting Elisabeth for the first time in Tallinn at the Baltic Congress of Endocrinology and ESE postgraduate course in April 2024. And from the very beginning, I was impressed by her outstanding research skills in adrenal diseases, particularly by her work on cyclic Cushing syndrome, which is precisely the topic of today's webinar. What makes this session even more valuable, I think, is that alongside discussing her findings, she will also provide us a practical guidance on how to conduct a systematic review with a bit of tips and tricks that will be, I think, incredibly valuable for this young audience. So without further ado, it is a great pleasure to welcome Dr. Elisabeth Nowak. Elisabeth, the floor is yours. We're ready to listen to your presentation.
Thank you, Ricardo. Thank you so much for the invitation. Thank you for having me. I'm extremely excited that so many people are online at this late time in the evening after a full day of work. I'm going to try to share my screen and then we can start straight away. I'm very happy to be here today and to present to you some of our work. I think I'm just going to start right into it. So I have no conflicts of interest with this talk. And Ricardo actually asked me to present our systematic literature review on diagnostic challenges in cyclic Cushing's, which we published in the Lancet Diabetes and Endocrinology in summer in 2023. On the right-hand side, I have a very short agenda of what I would like to cover today. So I would like to start with a brief introduction on Cushing syndrome, but of course also on cyclic Cushing syndrome with the definition of that. Then I'm going to give you an overview of the methods that we used in our review and present the results. Of course, we're also going to have a critical look at strengths, but also limitations. And in the end, I also want to give you a short outlook because the story about cyclic Cushing's doesn't really end here, but I think this is really just the beginning. And as Ricardo already said, I think cyclic Cushing's is a very, very specific topic, and I'm not quite sure how many of you have even met a patient with cyclic Cushing's. So to keep it a bit more practical, I thought it would be good to also include some, let's say, practical advice on at least my experience with systematic reviews so far. Okay, so let's start with some general background and a definition of Cushing's syndrome before we move on to cyclic Cushing's. So this is a picture of a review which is not ours. It's a different one. It's from Monica Gadelha, which was published in Lancet in 2023. And I think most of you are probably quite familiar with this, that when in endocrinology we speak of Cushing syndrome, that most of the time we actually refer to endogenous Cushing syndrome. And this, and I think you also all know this, is usually caused by a benign tumor, which most of the time is located in the pituitary, followed then by adrenal Cushing's, so when we have an adrenal tumor in one or both adrenals, or in rare cases, it can be ectopic, and then most of the time it is a pulmonary NET, so pulmonary neuroendocrine tumor. And then I think you also all know this, cortisol is doing a lot of nasty things to us, not just on the outside, but also on the inside. So on the outside, we see those typical changes, acne, the round face, those stria, the central obesity, hirsutism in females. But on the inside, we also have a lot of changes, such as psychiatric comorbidities, depression, sleep disruptions, and so on and so forth, but also cardiometabolic comorbidities, such as hypertension, glucose impairment, bone disease, as in osteopenia, osteoporosis, fractures, a lot of infections, of course, because glucocorticoids are immunosuppressive, and so on and so forth. So really quite a lot of bad things. And so when we have the clinical suspicion, what do we do next? This is also from this other review from Monica Della. So when we have the clinical suspicion of Cushing's and we have ruled out exogenous glucocorticoids, then what we do next is that we take at least 2 out of 3 diagnostic screening tests. So we always need the low-dose DEX suppression test, and then ideally also late-night salivary cortisol and or 24 urinary free cortisol. And if those tests are elevated, then of course, what do we do next? We look at the ACTH to distinguish if it's ACTH dependent or independent. And then depending on that, we proceed with our imaging, meaning pituitary MRI or CT of the abdomen. And if we suspect ACTH dependent Cushing's, then of course we can also do bilateral inferior petrosal sinus sampling to distinguish between pituitary and ectopic Cushing's. So let's proceed with our example patient. Here we can clearly see that she has clinical signs of Cushing's. And on the right-hand side, we see our biochemical parameters. These are actually stolen from a real patient with Cushing's, and we can clearly see that everything is grossly elevated. 24-hour urinary cortisol is elevated, DEX suppression test is elevated, and in Munich, we usually don't just do the late-night salivary cortisol, but we do a salivary cortisol day profile. And personally, I'm a huge fan of this because I think it gives you a really nice overview on what is actually also happening during the day. And you can really see how the typical cortisol rhythm is completely lost in this patient. Okay, so when we have the clinical signs and the biochemical cortisol excess, it's easy, right? This patient has Cushing's syndrome. Now we just need to find the tumor and it's solved. Now, the problem is, and I think all of you who have seen patients with Cushing's syndrome will agree on this, that most of the time it is not that easy. Sometimes we have patients with overt clinical signs, but where the biochemistry is normal. And sometimes it's the other way around, where the patient actually doesn't have that many signs, but the biochemical data says, oh no, there's quite a strong cortisol excess. And then sometimes there are patients where some tests are normal and some are abnormal. And in a subentity of patients with Cushing's syndrome, we see patients where those peaks, biochemical peaks, are interspersed by biochemical troughs. So this means that sometimes those patients have full-blown Cushing's, they have the typical signs, they have elevation of biochemical cortisol excess, and then all of a sudden, they go into spontaneous remission without anything that we have done, and then it comes back. And this is actually when we speak of cyclic Cushing's syndrome. So before we started our systematic review, we thought, okay, why is cyclic Cushing's syndrome actually of interest, or is it just interesting for us? So by the time we started with the review, this was in 2022, we had 4 patients in Munich with overt cyclic Cushing's, like very, very severe cases. And we had reported them in the literature. So we already thought, okay, I think, it might be underreported. The next thing is where we thought it would be interesting is that we didn't know if there were any common aspects of cyclicity, meaning if all those patients were like a certain subentity, maybe they were all identical in a way or not, but we didn't know anything about it. The thing that I think I still find this probably the most interesting point of this disease is that those patients seem to cure themselves. If you just wait long enough, they just go into remission, Cushing is gone. the same time, we don't know anything about the underlying mechanisms. And if you ask any expert on Cushing syndrome, it gives them a headache. And I think this is always also like a good indication of, that the topic might actually be quite challenging, but also interesting. So the aim of our study was actually, we had 3 aims. The first aim was to just produce a comprehensive assessment of common clinical and biochemical features of cyclicity in Cushing syndrome. The next thing is that we wanted to identify avoidable pitfalls during the diagnostic workup. And the third thing was that we wanted to detect if there were any differences in the clinical outcome compared to patients with non-cyclic Cushing's. Okay, so let's move on to the methods of our systematic review. Of course, we just started with some literature research. And really, it was just like that I went into PubMed and I typed in cyclic Cushing syndrome. And I'm going to show you what I found. So I typed in cyclic, but I ended up with fluctuation in the excretion of adrenocorticosteroids, intermittent Cushing syndrome, relapsing remitting hypercortisolism, variable hormonogenesis, cyclic hypercortisolism, cyclic hormonogenesis, periodic hormonogenesis, periodic remission with paradoxical dexamethasone response, and episodic cortisol secretion. So I typed in cyclic, but what I found were loads of different terms and aliases, all somehow describing some kinds of variations in cortisol secretion. Most of the times, not really a precise definition of what they actually meant. They just meant, some variations in cortisol secretion. The next challenge that I found, and this was actually when I was looking for a control group, is that I thought, okay, so when we have something that we call cyclic Cushing's, then, or like intermittent or episodic or whatever, then the opposite would probably be called non-cyclic Cushing's, right? So any other form of Cushing syndrome. However, there are 2 very nice manuscripts, I think, which were published in 2018 and 2014. And these are prospective investigations in patients with Cushing's disease, so pituitary origin only. And these are non-cyclic pituitary disease. So just a classical Cushing syndrome. And on the left-hand side, we can see prospective investigation of late-night salivary cortisol, always in the same individual. And on the right-hand side, it's a similar study, but of course, with different patients. And here they prospectively investigated repeated 24-hour urinary flow cortisols, also in the same individuals. And what you see in those zigzag lines is that if you test the same patient over and over again, you always get different results. Okay, and every now and then, even in a non-cyclic patient, the cortisol levels might be completely normal. And this is why it's also so important, and this is also mentioned in the current guideline recommendations, that ideally you should always have at least 2 diagnostic tests of the same, like 2 urinary free cortisols or 2 late-night salivary cortisols, to really make sure that you detect the hypercortisolism. So to summarize, actually, right in the beginning, we encountered quite a few challenges. First thing is that there was no uniform definition of cyclic Cushing's. Second thing is that there were loads of different terms, episodic, intermittent, periodic, and so on and so forth. The third problem was that really there weren't any large studies. There were only case reports and some small case series. The data quality was, quite varying. And the last problem was that really we didn't have a control group. So my mentor, Martin Reinke, and I, we sat together and we discussed, okay, so what can we do to tackle those challenges? And this is what we came up with. Since there was no definition, we just made up one ourselves. Because there were so many different different terms, we decided to actually go for 2 different search terms, one broader, just Cushing syndrome and cyclic, and then a second one where we actually looked for intermittent, episodic, periodic, relapsing, and all those different terms as well. Because there weren't any large studies, we just said, okay, we can't do a meta-analysis because this is what we had originally planned, but there was no way of doing it. We would just do a descriptive review. Regarding the varying data quality, we used a quality assessment tool, and the tool that we used for this study was the so-called JBI critical appraisal tool. This is a certain tool that is suitable for case series and case reports. If you do systematic reviews yourself, you always need to check which type of studies you're looking at, because there are different quality assessment tools. There are also some for larger studies, but this is something really important that you always need to do. And because there was no control group, we used our own. And I'm going to show you how we did that on the next couple of slides. Okay, so first thing, there was no uniform definition, and I have shown you previously that there are various chronotypes of cortisol excess. So if you imagine that we've got cortisol on the y-axis and time on the x-axis, and this shows the normal cortisol levels, then only when we have those clearly defined peaks and trough phases with complete remission or even subnormal cortisol levels, and then another peak, then we speak of cyclic Cushing syndrome. So this is the definition that we used. Some authors previously suggested to wait at least for 3 peaks. But honestly, I don't really know why, because I think it's just, a waste of time if we wait for another peak. If we have a patient who had 2 peaks, complete remission, another peak, then we know that he or she is definitely cyclic. So let's move on to some of the results. This is the first flowchart that you always see when you look into the results of a systematic review. It always seems as though it should be part of the methods, but really this is the heart piece of any systematic review, that you just show, okay, which search terms did we use, which articles were excluded and why, and which articles were included and why. So basically, Martin Reinke and we screened PubMed, Embase, and the Cochrane library. We didn't find any articles on the Cochrane library. We only found some conference abstracts on Embase, but that weren't peer-reviewed, so we didn't include them. So we really just focused on the PubMed research. As I said, we ended up combining 2 search terms. And in addition, we also did a manual checking of the references of key articles that we included. And then after excluding all the articles that didn't really meet our criteria, or where the definition wasn't really sure, or where there was no biochemical data reported, or where the data quality was really poor, we ended up with a total of 108 articles covering 212 cases. And of these, there were 3 larger case series where they also included a control group of non-cyclic Cushing syndrome. And from this, we were able to calculate an overall proportion of cyclicity. I'm not speaking of prevalence because it's not a population-based study, just a proportion. And then depending on the definition that we used, so either 3 peaks, then it's 14%, or 2 peaks, which is the definition that I prefer, then actually around 18% of patients with Cushing syndrome met the inclusion criteria of cyclic Cushing syndrome. Okay, so next we looked at 2 differences in tumor origin in cyclic Cushing syndrome. So these are the 212 cases from the literature, and we found that the majority was due to pituitary disease, followed by ectopic Cushing's, and most of the ectopic cases, patients had pulmonary nets or thymic nets. The next largest group were adrenal Cushing's, and then of course there were also some occult cases and some unclassified cases. So for example, where they suspected pituitary origin, but where they found empty cella, and then it wasn't really sure. And now we compared it to our control group of non-cyclic Cushing syndrome. And this part is definitely controversial. So what we did is that we combined from those larger 3 case series, where they had patients with non-cyclic Cushing's as well, we combined their data with patients from our hospital, the LMU hospital, also with patients with non-cyclic Cushing syndrome. And of course, in the literature review, we had a very detailed table of every single sub-cohort, but for the overall count, we combined them. And what we found that in non-cyclic Cushing's, pituitary is also the most common origin, of course, but then followed by adrenal. And here, and this is also a disadvantage, in our non-cyclic Cushing's cohort, we only had very few cases with ectopic. If you look in the general literature, you'll find maybe like 10% ectopic cases, but either way, in non-cyclic Cushing's, adrenal is more common, and in cyclic Cushing's, ectopic is more common, regarding the second most common part. Okay, so next we wanted to see if there was a cyclic phenotype. And so we had a predefined data spreadsheet, and we looked at all clinical signs of Cushing syndrome that there were, and we also looked at hypertension, diabetes, all sorts of comorbidities. And this was actually also the reason why we had to include our own control cohort, because the data from the literature, sometimes they didn't really report anything on comorbidities and control cohorts. So this was really the only way where we could do some kind of comparison. Overall, however, because the data quality was rather poor in the case reports, it wasn't really possible to do like any statistical analysis. We could just report, okay, yes, they actually present with the same clinical signs and with the same symptoms. But I have brought with me 2 case reports that I really, really like, and that I think really show how these patients change with cyclic Cushing's. So this is a very young patient. She's 6 or 7 years old. She's got a pituitary macroadenoma, so she's got Cushing's disease, and you can clearly see how she's got this moon phase, this round phase here during her overt phase. Then she goes into complete remission, and this remission phase lasts for about 6 months, and then she has another relapse. And you can clearly see that the longer the remission phase, of course, the clinical signs improve. And this is another case, and this is probably my favorite case from the literature. This is also a patient with a pituitary macroadenoma, and he was hospitalized for a couple of days. And he didn't just only have Cushing syndrome, but he also had psoriasis. And you can see this psoriatic skin lesions on his hand here. And as he had cyclic Cushing syndrome, and as his cortisol levels were increasing over a couple of days, his skin lesions vanished. And I think these 2 examples just really, really show how the clinical features of patients with cyclic Cushing's depend on the duration of their peak and trough phases. Other than that, regarding hypertension or any other, typical features, moon phase, central obesity, so on and so forth, we didn't find any, major differences compared to non-cyclic Cushing's. The next thing, and this was also quite challenging, is we wanted to provide a very detailed cycle characterization, because if you have a patient with cyclic Cushing's, you want to know when is the next peak gonna come. But this was actually impossible to do. There was no way with the quality of the case reports to do any good analysis or like combined analysis of the data. We found that overall, the cycles ranged from days to years, but here already we had the problem that the cycle was not always uniformly defined. So sometimes it was like from peak to peak, sometimes it was only the hypercortisolemic phase, so there were quite a few uncertainties with that, but overall it was very, very variable. Overall, we found that most patients have irregular intervals. So it's really rarely that you have a patient, who always has the same cycle length and then goes into remission and then comes back, 2 weeks later or something like that. That's very, very rare. The maximum duration of trough phases reported in the literature is between 3 to 5 years. And I think this is actually really quite astonishing. So some people really cure themselves for up to 5 years until they have another relapse. And from the literature cases, we also found that there were some cases, around 3%, that didn't just go into spontaneous remission, but that actually had spontaneous phases of hypocortisolism. Right now, we're doing another study where we are collecting further cases from all over the world. And here the rate is much, much, much higher. So our new data suggests that actually this rate is up to 30%. I don't know, we will have to have a closer look into this. But I think overall, it's just important that you need to be aware that if you have a patient with cyclic Cushing syndrome, sometimes they don't just go into remission, they go into adrenal insufficiency. Okay, so the next aim that we had is to look into diagnostic challenges in patients with cyclic Cushing syndrome. And this is really probably like the heart piece of this work. So we had a closer look at the diagnostic value of bilateral inferior petrosal sinus sampling. As you all know, BIPSS is used in ACTH-dependent Cushing's to distinguish between central and ectopic tumor origin. And what we did is that we looked for all patients who ever received BIPSS and where the results were clearly reported. And also we only looked at the ones with a stimulation, okay? So desmopressin or CRH. Back then it was still available. And what we found is that when you perform BIPSS during a documented biochemical hypercortisolemic peak, then it is 100% accurate. Okay, so then the BIPSS is perfect in distinguishing between central and ectopic tumor origin. However, when you perform BIPSS during a trough phase, then the results are not that good. And this makes sense, right? Because if you have a patient with ectopic Cushing's, but the tumor is not switched on and you do a BIPSS, then it falsely suggests pituitary origin. And this really is a problem because those patients are then falsely operated on a pituitary, let's say, microadenoma or just an explorative pituitary surgery. And sometimes those patients do go into remission, but it was a spontaneous remission. And then you think, oh no, you've solved the problem, but the patient actually comes back with another phase of Cushing's, and the tumor has been, like, let's say, in the lung or in the thymus all the time. Just a short overview on differences in treatment and outcome. So we've got our cyclic Cushing's on the left-hand side, non-cyclic on the right-hand side. And here I just put some of the key findings that we looked into. Here, the last number is always the number with available cases. So this is also something that we really made sure of, that we always reported how many case reports really had this specific findings. So overall, we found that patients with Cushing's disease who were cyclic were for some reason not as often operated as patients with non-cyclic pituitary Cushing's. I think this may be due to the fact that sometimes, the picture is really confusing, or then they just cycled off and then you maybe just wait and don't really operate them. We also found higher rates of relapse after a successful surgery in patients with cyclic Cushing's. Some of them were even just diagnosed to be cyclic after the first pituitary surgery. And this then caused some authors to, assume that maybe the surgery triggered the cyclicity. Personally, I don't think this is the case. I think this may be due to a bias, because after transsphenoidal surgery, what do? You have a close look at your patient because you want to make sure that they're in remission. So you do a frequent biochemical post-operative workup, and I think you're just more likely to detect, any cyclicity. We also found that patients with cyclic Cushing's are treated with pharmacological therapy much more often. This is usually the use of steroidogenesis inhibitors. And this is also something which makes it extremely difficult to distinguish a cycle length. Because if you put a patient on, let's say, ketoconazole and metyrapone, and then you don't really know, maybe they would just have cycled off spontaneously, but it makes it really, really hard as soon as you put them on any kind of adrenostatic medication to say, okay, when did one cycle end? When did the next one start? There was no difference in rates of bilateral adrenalectomy, but the overall remission and control rates were significantly different. So we found that more patients with non-cyclic Cushing syndrome went into full therapy-induced remission, not spontaneous remission, therapy-induced remission, compared to the cyclic ones. And also the cyclic ones had, I think, 9% is quite a high rate of unnecessary tumor surgeries, usually due to a misdiagnosis. Also, the median time to induced in remission was significantly longer compared to non-cyclic Cushing's. This is a table which cost me several weeks of my life, I think, but which had to be moved to the supplement. But I think I still want to show it to you. So, of course, we also looked into possible underlying mechanisms of cyclicity. And we tried to group the case reports that suggested different mechanisms altogether. But the more research we did, for every argument that we found which was supportive of one reason, we just found as many case reports that said, okay, this doesn't make any sense. So just to give you an example, some articles suggested, okay, this has to be, the underlying mechanism is probably hemorrhage or necrosis, because we can see it on the MRI, or we can see it in the histopathology report. But at the same time, we had actually quite a few cases where neither the MRI nor the histology showed any infarction or necrosis. And also, this still doesn't really explain why there would be another relapse, after necrosis. Why would then the tumor blow up again? Other possible mechanisms are always, or that were discussed, were always like external factors, but there we don't have any evidence for any causal relationship. So until now, until today, we really have no idea of the underlying mechanism. So to summarize the take-home messages from this review, we think that cyclic Cushing's may be underreported. We would always suggest to suspect cyclic Cushing syndrome in any patient with a previous history of cortisol excess, or where the clinical and biochemical findings are not matching. In this case, I think it's always quite helpful to let you show pictures of patients as well when they tell you, oh no, I look completely different half a year ago. Just like, look at photos of them. Late night salivary cortisol is perfect to identify short-term variations. And this is also very reliable and very practical for patients who live far away. You can just give them a batch of late night of the tubes, of the saliva tubes, and tell them, okay, so when you feel that you have like another episode, you just take the saliva and then you post it, and then you can analyze it. If you just want like a more proof of concept, then of course you need hair or something like that, but that only works in patients with long hair. Bilateral petrosal sinus sampling is perfect in distinguishing between pituitary and ectopic Cushing's, but only if you perform during a peak phase. Patients that were put on adrenastatic medications, in our view, should be put on block and replace therapy, because in a patient with cyclic Cushing syndrome, you have no goal where you can titrate the medication to, right? Because the urinary free cortisol is always varying all the time. And last but not least, of course, we need to identify the underlying mechanisms. This is my personal view of cyclic Cushing's, and it might be wrong, but this is just what I believe now. But I'm also a bit biased. I think by now that every patient with Cushing's is somehow cyclic. And I think, that we have those variations in every patient, but then only when we have these very strong peaks and troughs, this is when we speak of cyclic Cushing's. Personally, I also don't like the term cyclic, because I think it suggests that there is a periodicity behind it. But from all that we know today, it seems to be very, very irregular. Okay, so let's have a look at two strengths and limitations. So I think our review was indeed very detailed and very, very comprehensive. We really tried to squeeze the case reports. But of course, there is always reporting bias, because many case reports were probably, never published, and maybe they only published the ones with the, most extreme cycles, and the data was in general very, very heterogeneous. Another strength is that we've really tried to have very clearly defined outcomes and a very transparent reporting. Like, we always reported, okay, this was not reported, so we couldn't really analyze it. But this was also, due to the limitation that there was just a large number of missing variables. Another strength is that we ended up using 2 search terms, and we searched 3 databases. But at the same time, we cannot rule out that we have overlooked cases with true cyclicity, or on the other hand, included cases, with just some sort of variation, but not true cyclicity. And this was also something that was discussed during the revision process of this manuscript, is our own cohort, which we included. I think the major advantage here was that at least we had a nearly complete data set. We had a lot of data on comorbidities, clinical appearance, and so on and so forth. But of course, this also introduces bias, and any differences observed between the cyclic and the non-cyclic Cushing's may not reflect any true differences. So just a quick outlook, what is coming next. So right now we were working, so my mentor Martin Ranke and I, we were working on the first international case series on cyclic Cushing's. So we wanted to detect if there were more cases out there. And we have just, I'm really happy about this. We have just completed the enrollment 1 or 2 weeks ago. And we managed to include another 112 cases of previously unreported patients with cyclic Cushing syndrome. And we'll present the results during the European Congress in Copenhagen. And this is a study that I'm really excited about. We are also working on the first international multi-center prospective study on cyclicity in Cushing syndrome. Here, the recruitment is ongoing. We're working together with our partners, Christina Isand in Tallinn and Professor John Wass in Oxford. And here we're doing prospective screening of patients with suspicion of cyclicity, but also with proven Cushing's in general. And we want to answer the key questions: how long should we screen a patient to actually say, does he or she have cyclic Cushing syndrome, or is this something else? And at the same time, we want to improve our knowledge on, if every patient, somehow is cyclic. Okay, so as promised, this was just an overview of the paper, and now I just want to give some general, or provide some general aspects for systematic reviews. So if you yourself maybe want to do a systematic review, or if you're reading a review, there is no way around this website, which is PRISMA statement. And the PRISMA guidelines are very, very thorough guidelines, or provide very thorough guidelines on how to conduct a systematic review. And this is always the first flowchart that you will see in any systematic review. And there are different versions of it, depending on if you have different databases or other resources as well. And this always helps you to have a clear focus on reasons to include or exclude articles. The PRISMA guidelines also have a very, very precise checklist, which also, for example, if you publish with the Lancet Diabetes and Endocrinology, you have to upload this checklist, and you have to state exactly where every single category on which page in your manuscript you have addressed this aspect. And I think during the writing process, this was actually really helpful for me, because if you do a lot of reading, at some point you just get lost, in the middle of so many different papers. But this really helps you to have a very, clear idea of where you need to go. And then I found this was also very helpful. So, you all know the Cochrane Library. And there is a Cochrane handbook for systematic reviews of interventions. And this was, I think, very, very helpful, and gives you some very practical advice on especially, for example, also how to merge data. So in our review, we sometimes had the problem that some patients or some authors reported, let's say, median age, and some reported the mean age, and some reported the absolute values. And it also gives you some, for example, statistical advice on how to merge those data, or advice on how you can, or when it's appropriate to impute data, or when it's more appropriate to just leave the data out. These are just some general questions that I would suggest that you should ask yourselves before you would like to start a systematic review. So the first thing, of course, is to check if the topic is of general interest. So I think it's always a good idea to discuss maybe with a couple of colleagues, or maybe especially someone else outside of your institution, if he or she thinks that this sounds like something worth investigating. The next thing is quite important. You need to check if there is enough literature. Actually, last week, I had another idea to conduct a systematic review, and I was really excited about it. And I went to my mentor, and I was like, oh, I want to investigate this. And he was like, okay, did you check? Is there any literature on this topic? And then I checked, and I think there were 7 articles. So there's no point in doing a systematic review. The third thing I think is probably one of the most important things. Have you tried all different search terms? Because the search terms, they are the key to any systematic review. If the search terms are not well chosen, you can throw the whole thing into the bin. They will not be worth anything. You will overlook articles or you will include the wrong articles. And if a reviewer criticizes your search terms, you can start all over again. So this is really, really important. And I think it's important to spend a lot of time on the search terms as well. Then, of course, you need to check if there are any systematic reviews on the topic already. And if there are, you can still do one, but then maybe it doesn't make sense if the review was published last year. But if it was published like 10 years ago, then maybe there is new literature. But then, of course, you need to adapt the range of articles that you're looking at. You need to define all outcome variables before you screen. And this sometimes, of course, needs some refinement during the screening, because then you notice, oh, actually, they always report something else. So you might have to include another outcome variable as well. But then you have to relook at all the articles that you already screened, and you need like a predefined data spreadsheet. You also need a study protocol, which usually has to be uploaded when you publish a systematic review. And you can consider if you want to register your review. There are like websites such as Prospero, where you can also check if maybe someone else is working on the same topic. And then, if they're faster, it's like all there for nothing. With our review, we actually didn't register it because we had to refine the search several times. And in the beginning, we didn't really know if we would find anything. And this were the reasons why we didn't register it. And last but not least, but I think this is the very most important aspect when you do a systematic review, you need a buddy. I don't know if you have IKEA in Italy. I think you do. In Germany, everybody buys all the furniture at IKEA, and it's no fun to, build a wardrobe by yourself, but it's definitely no fun to do a systematic review by yourself. And you need a sparring partner who is, first thing, screening every single article independently of you. And then ideally you have a third person who is, the communicator if you disagree on whether you should include or exclude an article. But you also always need someone who is like guiding you through this, because if you do a lot of reading on a very specific topic, sooner or later, at least in my experience, you get completely lost. And so it's very, very important to have a buddy. And with that, I would like to close, and I'm thanking you very much for your attention. Of course, I thank Martin Reinke, who is my mentor and who was my buddy in this process, and who screened all those articles with me, and without whom this wouldn't have been possible. And I'd like to thank my research group and Ricardo, of course, for the kind invitation. And last but not least, Munich is not so far away from Italy. So whenever you feel like it, I think it's definitely worth a visit. The city is really, really nice. I like it more in summer, but it's also nice in winter. We have some very nice lakes around here. For example, we have the Tegernsee. And on the top left, this is our new university hospital building. Here you can still see the old building, and those two are connected. And this is really nice. And this is right in the city center. And this is also where I work. And then we still have the old campus, the big campus, which we call the Toaster for obvious reasons. And this is in Großhadern. And I think Munich is always a nice place to visit. And if you want to come, I'm happy to show you around. So thank you very much for your attention.
Thank you very much, Elisabeth, for this wonderful presentation. Very well presented, and I'm sure very well received from the audience. And I'm also sure that this will probably instigate some fancy discussion. I do have some questions, but I want to leave the floor to the audience. But while we are waiting for questions from the audience, I just want to ask you or provoke you a bit about your insight. What is your feeling about this disease? Because we do know that it's very difficult to be diagnosed and recognized by even, I don't want to say expert, but a normal endocrinologist will struggle in recognizing that. But in your point of view, you're now seeing a lot of patients, you're now treating a lot of patients. do you think that cyclical Cushing is a different disease? I think you mentioned something about it, but I just want you to stress a bit more about what is your personal feelings about that. Because if you look at the prevalence of the etiology, it seems that you have two different diseases there in front of you. And well, you couldn't confirm this by, you know, finding any kind of backgrounds or histology or even in clinic, you can't really dissect what is one and the others. What is your feeling? How would you recognize one or the other?
Yeah, thanks, Ricardo, for this difficult question. So my personal view really is that Cushing syndrome in general is a spectrum disease. And I think this, to me, this is already evident if you look at a patient with non-cyclic Cushing's. If you test the same patient over and over again, you always get some different results. And I think this somehow makes sense because we still, you know, it's a tumor, and the tumor is not always secreting amount X of cortisol or ACTH. And why should it, right? And I think there are some patients, you know, there's some variation in any patient, but it's just more extreme in some patients than in others. And if those patients with these very extreme cycles are a completely different entity or not, we don't know. I don't really think it's a different entity because other than that, they present exactly the same. They have the same features, they have the same comorbidities. So I don't think so. Yeah, I don't think it's a different entity. I think it's a spectrum, and we're just looking at one end of the spectrum. At the same time, I think it's very important to look at this end of the spectrum, because if, you know, in 10, 20, 100, whatever years' time, we're able to identify the underlying mechanisms of how those patients go into spontaneous remission, then I think we need to, you know, use this knowledge to translate it to all sorts of Cushing's. But we don't know.
And still not a question from the audience. I have a couple more for you. Regarding the diagnostic tool.
Yeah.
You mentioned what is the normal path that you would ask for diagnose Cushing syndrome, but I want you to tell us a bit more about hair cortisol. If you think that might be a future in this case, or you would rather use any other tool in clinic.
Well, the thing with hair cortisol is that you need someone who's performing it, right? For example, we don't do it in Munich. So if we wanted to test hair cortisol, we also have to send it somewhere else. So if you're interested in hair cortisol, you first need to check, you know, who is performing it and if they have established reference ranges. Then, of course, there are always some issues with hair in general. Many patients have short hair. You can't really do anything with that. Many patients with Cushing syndrome don't want to donate any of their hair because they are complaining of hair loss already, and they don't want to give it to you just for fun, right? You know, and then if people dye their hair or something like that, that might also affect the cortisol levels. I think in some cases, hair cortisol is good to have, as I said, like a proof of concept. So if a patient maybe, you know, says that they had an episode 10 years ago, but you don't have any, you know, evidence of that, but they have long hair, then of course you can test. At the same time, what's the use, right? I think the most important take-home message is that cyclic Cushing's is still Cushing's, and Cushing's disease is Killing's disease. So we shouldn't waste any time doing fancy diagnostics, but we should treat those patients accordingly. And I think in cyclic Cushing's, it's just really important, especially when we opt for medical treatment. And from my experience, this is more often the case because many of those patients are ectopic, and then it takes longer time to identify the tumor origin. But if we put them on steroidogenesis inhibitors, I would advise to go for block and replace therapy, but then to really block them. And this is like some problem that we have in our department all the time. Most of the time, we're too shy to really block them. We just give them a bit of metyrapone and a lot of hydrocortisone to make sure that they don't go into adrenal crisis. And then they have Cushing's, and we give them additional hydrocortisone. So if we treat them, I think we really need to treat them. Yeah.
Good. We do have a question from the audience now by Soraya Pugliesi. And Soraya, of course, congratulates you with the great presentation. But the question is, in your experience, are there differences regarding the common complication of hypercortisolism between patients with cyclic Cushing and patients with classic Cushing?
So no, so far from the data that we have, we don't have any information on complications as in, let's say, comorbidities. Okay, so for example, if you look into cardiovascular events, we don't have any data if they have them more often or less often. But it seems as though they have more often unnecessary tumor surgeries, which I would consider an iatrogenic complication. This is our fault because we didn't do the diagnostics right. And another complication definitely is that most of the time the time to treatment takes longer, because the biochemical tests, they don't really make sense. You test again. So I think complications really are related to challenges during the diagnostic process. Yeah. And then maybe, we don't know about all those patients that are out there, but that just went into spontaneous remission. We don't really know what their cortisol is doing at the time when they don't come to our department, right? So if they have like a mild hypercortisolism all the time and we don't treat it, they might have higher rates of cardiometabolic diseases, but we don't know.
And along the same lines, you showed us that patients with cyclical Cushing disease more often have relapse after surgery. But how would you recognize? Because we already know that Cushing disease relapse a lot after surgery. Yeah. So how would you recognize a cyclical?
Yeah. That's a very good question, and this is also what we are looking at into the new prospective study that we're doing now. So one group of patients that we're particularly interested in is patients with Cushing's disease that had successful pituitary surgery, then went into remission, and then have a relapse. And the thing is, I think, as I said, I think there is a bias, in those patients. We just test in general, we just do frequent testing, and at the same time, if we just move their cortisol level from here to here, they're just closer to the normal range. So maybe they're not even cyclic, maybe they're just around the upper limit of normal all the time because we already removed a big part of the tumor. And this could, also introduce a bias. But we're particularly interested in this group as well. So we have to see.
I'm bombarding you with questions. I just wanted to wait for some other question from the audience. I think they are too shy, or this is very rare. So that's probably for experts, at least in clinic. I do have some more questions though.
Keep going.
Just because I'm curious, in clinic, are these symptoms really reversible? I mean, I expect the glucose metabolism to be completely reversible sometimes. But for other clinical phenotypes, do you really expect the phenotype to go back to normal?
Yeah. It depends. It depends on the comorbidity, and it depends on the trough duration. As you said, if you have a trough duration of, let's say, 3 years, of course, the glucose metabolism, is going to normalize. But if you have, for example, severe skin lesions or osteoporotic fractures already, or those stria, those are never really going to normalize, right? So I think it really depends on the duration of peaks and troughs there. Yeah.
Great. Okay, so lots of things still to demonstrate and to study, Elisabeth.
Yeah.
How is going your prospective study? Are you enrolling on a good rate, or? Well, this is a good opportunity to advertise in Italy. For we have lots of audience. So if anyone wants to share any date with you, shall we just contact you? Or
the thing is, for the prospective study, there's like a really tight protocol to follow, and it was a really difficult to get it through ethics, especially in the UK. One thing, for example, is we're planning, I think we discussed this, on doing weekly DEX suppression tests. So we need to find patients who are willing to do that on a weekly basis. So for that, I think it's going to be difficult, to contribute a lot of patients. And for the other study where I said that we're the case series, that I'm really happy. We're aiming to recruit 100 patients, and now we managed that. And I'm soon going to start analyzing all those data, and then we'll present this in May during the Congress. Yeah.
Great. Looking forward to it.
Thank you.
So we do have a question from someone who you probably know, which is Ilaria. Thank you very much for this amazing overview regarding this complex topic. In your opinion, are there any clinical variables that predict the eucortisolism, hypocortisolism phase in cyclical Cushing syndrome? And this is the first question. The second one is, compared to non-cyclic Cushing, are there any differences that you think might explain this?
Yeah, thanks, Ilaria. I think it's a very difficult question. I mean, actually, I would like to ask the question back. I mean, do we have any good predictors for eucortisolism in Cushing's, like non-cyclic Cushing's? I don't know. I think just adequate treatment, maybe, right? Like aggressive treatment. Then we know that they become eucortisolemic. In cyclic Cushing's, we don't have any clear predictions on when the next cycle is going to come or not. But what we do know, and this is also becoming evident from the case series that I'm analyzing right now, is that some patients always have the same symptoms during a burst. So some patients really notice that, for example, their hypertension is getting worse. Many patients have like continuous either blood glucose monitoring because they have diabetes anyways, or they just do regular measurements of their blood pressure. And when they notice that this is getting worse, then they know they have a new cycle. And at the same time, if this, is improving, if the clinical parameters is improving, then we know, okay, probably they're going back into remission. But we don't have anything, good, like as a real, like a prediction tool. And the next question, compared to non-cyclic, I think this also refers to predictors, right?
Different question. Yeah, thank you.
Yeah. No, not really.
Okay, other questions coming. Sorry for that, Elisabeth. Just tell when you need to go.
No.
So Fabio Violetto congratulates with you for the great presentation. The question is it? Oh, yes, you can ask live, Fabio. Yes, of course you can. Everyone could.
Hello, thank you very much. I couldn't write the question
Fabio.
because I'm from the cell phone, so I cannot type.
No worries, Fabio. Go ahead.
So, congratulations for the great talk. My question is about the molecular aspects, and in particular for the interpretation of cyclic Cushing disease or syndrome as a spectrum, because, for example, we have the example of the molecular data from the adrenal tumors, in which molecularly we have this spectrum of tumors with Wnt beta-catenin mutation, which encompass non-functioning tumor and MAX, and then we have like a completely different tumorigenesis pathway, which is the PKA pathway, which is related, for example, to adrenal Cushing syndrome. So this is just an example to say that not always what clinically or biochemically seems a spectrum, it is really a spectrum from a molecular point of view. So my question is if in the outlook in the future you plan also to explore this aspect, comparing molecular data from cyclic Cushing disease and non-cyclic Cushing disease, and if you have any plan about that.
Yeah, thank you, Fabio. I think this is a very, very important point, and I think it's good that you made it clear. And of course, I also completely agree that the clinical spectrum may not be the molecular spectrum, so that's a very important aspect. Yeah, as you know, for the case series, we also asked every center if they had any tumor tissue available, and this is something that we would probably do like in the next, or definitely in the future. Right now, I cannot say how soon, because right now at the moment we don't really know what we're looking for. At the same time, it's difficult because we have pituitary cyclic, ectopic cyclic, and some adrenal cyclic Cushing's. And I do think, for example, and also in the literature, patients with PPNAD, so primary pigmented macronodular adrenal disease, they are supposed to have much higher rates of cyclicity. But like right now, when we did the case series and we asked to all different centers all over the world, we don't have one single case with PPNAD. So I think their molecular mechanism is probably also quite different from a patient with Cushing's disease. So yes, this is something planned for the future, but I think until then, we still need to do this sort of pattern recognition approach to identify which molecular target we're actually looking at. Yeah.
Thank you very much. Thank you.
Thank you.
We do have another question from Lorenzo, which is asking you, after congratulations for the terrific talk, if you think that any omics approach might be helpful in distinguishing these two different diseases.
Yeah, thanks, Lorenzo. I think this is also a very, very good idea. I think here we probably have the same problem right now, that so far all the data that we have is retrospective. And I think for any kind of omics approach, we need new patients. We need fresh data, fresh samples. And then, yes, this is definitely something that would be possible. At the same time, it's probably going to be difficult because we will need many patients and clearly cyclic and non-cyclic Cushing's. And this is also something which is always going to be a limitation of this whole cyclic non-cyclic thing. And this is also something that was asked quite critically during the revision process, for example, is that even in a non-cyclic Cushing's patient, we never know if they're really non-cyclic, because we only test them when they come to our department. So this always makes it really difficult to have this distinguishing, cyclic, non-cyclic. And I think this could also be something probably that makes it difficult to do any kind of omics, because there will always be this sort of limitation. But yes, definitely. But I think more in a prospective way, and if we have a better idea of really what we're looking at. I would like to ask a question to the audience. Yeah. Since you are all experts, have any one of you ever experienced some sort of cyclicity that is not related to cortisol or ACTH in any other endocrine disease?
Good question.
Let's say acromegaly or hypothyroidism or anything else, because I haven't. And I've done some just short literature research, and I didn't find anything similar.
That's a good point. Interesting. Yeah.
And I don't know why. Why would it be, specific to? I mean, of course, we have the circadian rhythm, which is closely linked to cortisol secretion. But it should be similar for other hormones, like growth hormone, for example, right? So. Yeah.
But I think that's a really good point, Elisabeth. Any comments on this from the audience? Any insight? No?
We don't know.
Destroyed us with your question, your last question. No, thank you very much indeed for your time, Elisabeth, and for the presentation as well. If there are no other comments or questions for Elisabeth, I think we can say goodbye to her. So thank you very much indeed, Elisabeth.
Thank you so much for having me. It was a pleasure, and I'm really, I think you're a great community. I don't think that there are so many Germans in the German young society at this, time of the day that do random talks on a random rare disease. So thank you very much for having me, and
thank you very much indeed, and look forward to see you next time in at ECE, right?
Yes, definitely. Yeah.
Bye. Thank you.
Bye. Thank you.